also complementary. And in reality, in the patient with the CABG, with the first revascularization bypass surgery, after 5 years, need to subsequent PCI 11.7%. And in the group with the first revascularization PCI, after 5 years, need for subsequent bypass surgery 7%. And they do extrapolation from the data from German 2015. They give estimation within 5 years, 6,000 PCI for the bypass surgery and 3,000 bypass surgery after intervention. And according to the European author, they give how we can choose the strategy for repeat revascularization of score. We met it on the basis of the heart team, and some factor can give more look like according to guidelines, such as the European guideline or American guideline, patient preference, resource, and operator skill is very important. Sometimes we have a very good choice, but we cannot do. And some factor of the anatomy can help us to choose med decision, such as if an anatomical complexity of coronary artery disease, it go to the bypass surgery, it less anatomy, it's suitable for intervention. If the heart failure, it improved for bypass surgery, preserve the ejection fraction, improve for intervention, or diabetes, or few comorbid condition and high morbid condition, improve for the intervention. And low SDS score risk, high SDS score, and non-emergency clinical emergency. So it's the some factor can help the interventional cardiologist can make the decision which strategy we will do for repeat revascularization. And this is the recommendation of the ESC guideline. If the patient after bypass surgery, the CABG is reduced, but sometimes the intervention is a good choice, particularly as you see, PCI for the bypass native artery should be considered over PCI of the bypass tract. It means if we do repeat revascularization in the patient with reverse bypass surgery, better we do to the native coronary artery. And DES and for the treatment of in-stent restenosis of stent, DES are recommended. And this is look like you have your discussion, DCP. According to the guideline of ESC guideline, DCP is still a class 1A. The difference between two sides of Atlantic Ocean. And if the patient have many recurrent episodes of diffuse in-stent restenosis, bypass surgery should be considered. However, in our reality, particularly in Vietnam, and look like some similar to the many countries, PCI is almost the only option because patient refusion of bypass surgery, or maybe high-risk patient for surgery, or need to revascularization after bypass surgery, and cardiac surgeon do not like to do repeat revascularization, in particularly a triple vessel disease with full metal jacket, nowhere to insert a bypass graft. And the diagnostic tool of score look like it is similar to the presentation of Dr. Michael Lee. Intravascular imaging always be recommended to assess the neo-intimal hyperplasia, OCD, and IVUS, to assess the neo-atherosclerosis, to assess the late acquired malabsorption, to assess underexpansion. It's very important for us to determine which strategy to do, or to assess evagination, to assess stand thrust, to assess S dissection, so on. So according to the guideline of ESC guideline, IVUS and or OCT should be considered to detect a stent-related mechanism. So we can match how with the strategy of revascularization according to corollary anatomy, medical comorbid, experience, or our skill, and particularly based on preference. And I have some case for demonstration. The first, I would like to present one case with post-bypass surgery to repeat revascularization. The first, you can see 5 years ago, 5 years ago. This means the patient were bypass surgery in 2013, and after 5 years after coronary angiogram, you can see a small diffuse lesion in the right coronary artery, and diffuse lesion all of the left coronary artery, particularly distal left main involved to the pole ostium of LAD and circumflex. And obscure cardiac surgeon then like to do repeat bypass surgery because the first, the scare, lima, and a very small vessel where we can position, we can insert the bypass graft. So after do explanation and with the preference of the patient, we made the decision to do PCI for repeat revascularization. And the lima, as you see, the patient have one patent graft from graft. So according to guideline of ESC guideline, we made decision to do a PCI to native coronary artery. And before we perform PCI, we think may be very difficult, but when we do the PCI, I think not very difficult for us, for all mode of us. You see, for the right. And in that time, we don't have the intravascular image, so we cannot recording the image intercoronary, and the left more a little bit more difficult. Get it better, and we begin to do a two-stand technique for distal left main. With the decay cross, reverse decay cross, the left main go to the circumflex. What? And the last result. Also, I think the last result look very good when we can compare with the pre-PCI. And I think this guy, in the view of the technique, not very difficult. You see? And by now, I like to solve 2K with the instant stenosis was beside repeat revascularization. And most of K instant stenosis. I remind in the presentation of Dr. Michael Lee, Dr. Michael Lee have a talk very clearly and meticulous So I remind very quickly. The first, we have a long time Moran system classification for instant restenosis according to coronary angiogram. Pattern 1, focal. Pattern 2, diffuse. Pattern 3, proliferative. And pattern 4, occlusion. This classification on the basis of coronary angiogram. But nowadays we have the mechanism of instant restenosis or more detailed, more meticulous, and more exactly. The first, the group of biological neoatherosclerosis drug-resistant hypersensitive neointima, and group 2, the technical mechanism apply blood rupture, fracture, geographic mix under expansion. I think that similar to Dr. Michael, my presentation multicolor. And this is the reason why we need one more classification of instant restenosis. The first prior classification on the basis of angiography, but by now we have intravascular imaging. And the first classification would be on the basis of bare metal stent. By now, bare metal stent not exists. And we have intravascular imaging is cornerstone to define. And this Wattman classification will build in the mechanism. So it helps us to understand the mechanism of failure to guide the individual treatment option. So we have the Wattman classification: type 1 mechanical, type 2 biological, type 3 mixed pattern, type 4 CTO, and type 5 multiple stent layer. We go quickly in type 1. We have on type 1A under expansion and type 1-2 stent fracture, and with type 2 biolosis, type 1, type 2A neointimal hyplasia, type 2B neoatherosclerosis without calcify, and type 2C neoatherosclerosis with calcify. Type 3 mixed mechanism between type 1 and type 2. And type 4, you can see CTO have the difference with the previous slide. We don't have the demonstration for intravascular image because it's a CTO. You cannot record the IVERT or OCT. You still record IVERT OCT after you open the lesion. And type 5 multiple stent layer. And I have two case for demonstration. The first case with the type 4 and 5 instant restenosis. Type 4 is mean total occlusion, and type 5 on the basis of having many greater than 2 layers of stent. You can see here the patient after 5 years ago, the stent intended to the rigorous artery disease. By now, compared with the total occlusion of the stent of the distal RCA and mid vessel. And we must wiring through, and we must do pre-dilatation to record intravascular image. So after we open the CTO, we use the IVERT and OCT to determine mechanism leading to restenosis. Here you can see this is OCT. You can see a 2-layer stent. And you can see after we open the lesion, plaque burden of the atherosclerosis is very large. The patient have two reasons for stenting, the distal and the proximal. And proximal is okay, and one layer of stent, but some pre-stenosis, but not significant. But the distal, you can see two layer stent. But this vessel, the last vessel, so I think we can manage. It's not very difficult. Calcify. So we continue to use the cutting balloon to cut the lesion. After that, we use NC balloon and we stenting. And this is the last result pre-PCI and post-PCI. And this is the image. Let's see. Because the assistant doctor not enough strong, so they inject the contrast not strong. It's slur. But we can see the no plaque burden inside the lesion. I think it's okay. So why? And this is the stenting proximal region. It's okay. And the case number 2, you can see after 1 year stenting the LED, it by now a total occlusion. The first, we try to rewiring, and to open the lumen. It's okay. And by now, we use the second technique of intravascular imaging, IVAS. IVAS, you can see in the basin. The distal segment. We can see pre-stenosis before stent. Because go in the stent, you can see pre-stenosis. After we cut the balloon, 1 layer stent, along large plaque burden along the stent. And we have overlapping stent. So this area, you see 2 layer stent. You see very clearly. 1 layer stent. Because large burden of plaque, we do 1 more stent. So by now it become, if it recurrent restenosis, it become a type 5. The last result, it looked very good. And this is the intravascular image. But now you see two-layer stent. And in the overlapping region, you can see three-layer stent. Two-layer stent. Look like three-layer stent in the overlapping. So this is the last result compared with the before intervention. So some take-home message for the young interventionist. Nowadays, in daily practice, the interventional cardiologists encounter non-small amount of the repeat revascularization, including previous stenting or bypass grafting. The frequency about 10 to 15%, not small. The technique of PCI is more difficult and challenging, and outcome and prognosis often worse than the first revascularization. And interventional cardiology choose strategy of revascularization on many factors, coronary anatomy, and previous technique, their skill and experience, the patient preference, and comorbidity of patient. And intravascular imaging can provide useful information to guide treatment decision. Young interventionists should learn knowledge in interpretation of angiogram, intravascular imaging, and learn to utilize necessary toolkit. Okay, thank you so much for your attention.
Great, Dr. Dong, excellent presentation, and thank you so much. You talked about the use of intracoronary imaging. How often do you use intracoronary imaging to guide your PCI?
Yeah, you asked me in the situation instant stenosis or okay?
All cases, let's say non-ISR cases, what percent of the time do you use intravascular imaging to guide PCI?
I think about 10%. 10%. I use the intravascular imaging to guide the treatment. About 10% for the case, complex case, or for the repeat revascularization, or for the very calcified lesion, or maybe after we are stenting something wrong, we use. So only 10%. I think less than Dr. Vũ Hồng Vũ of UMC.
Right. And is there any reason why you would not use more, or you feel pretty confident that you have full stent expansion, in particular those soft lesions as opposed to calcified lesions?
Yes. In calcified lesion, we use the cutting balloon, a scoring balloon, rotor ablator. And I have one question for Dr. Michael and Dr. Sandeep Nathan. Today, in my presentation, I present 3 case, easy case. But in reality, I encounter some very difficult case with the type 4 and 5 restenosis, such as the patient have 2 or 3 layer stent already. And by now, the patient have a restenosis with the mechanism under expansion. And in Vietnam by now, we have only cutting and scoring balloon. We have rotor ablator, but rotor ablator we don't dare to do in the long and tortuous the stent. So we have only two measure: drug eluting stent and drug coated balloon. Finish. So the patient have this situation. They recurrent instant stenosis 3 times, 4 times, and when he come back to our cath lab, I just only open by the balloon and to do the drug coated balloon. It finished. But I hope and I hear about lithotripsy in America. It can solve this because when I use the NC balloon with very high 24, 25, 30 atmosphere, we cannot open the under expansion stand already because it's very hot. So can you give me advice in this situation?
Yeah, what I would do if, first of all, IVL would be a great application, although there's a paucity of data. But number two, do you have laser in your cath lab?
No.
Okay. Well, if you did have laser, sometimes we like to give contrast while doing laser because you could cause micro explosions to help expand a stent, let's say, because there's calcium. There are some newer balloons where the rated burst is almost 50 atmospheres. So going very high pressure, but if he has recurrent ISR, I think surgical revascularization should be considered. Sandeep, I'll open it to you.
Yeah, Michael, I agree with that. I have some slides actually in my presentation, so maybe I'll just defer a full answer until then. We have used C2IVL, and before the coronary balloon was available, we've used the below the knee peripheral balloon in coronary arteries that are appropriate size. It becomes an issue of diminishing returns, in my opinion, in the situation where you have 3 layers of metal. If you have 1 layer of metal and it's underexpanded, I think that contrast lasing and shockwave both work pretty well. I think if you've got multiple layers of metal, as Michael said, I would be thinking about the OPN NC balloon, which is now finally made its way into the United States. That's the balloon with the rated burst pressure of 50 atmospheres.
50 atmosphere. Oh.
50.
Which is comparable to what you get with an IVL balloon. Obviously, though, with IVL, you could inflate at 4 atmospheres and cause very little barotrauma. At this point, I'd like to open up to the other panelists. Do we have any other questions for Dr. Dung?
I have some comments. So in our physiology, in all of us, physiology to prevent is much more better than just method. So to prevent the instant restenosis, so do we think that we use for hundreds of cases of the intravascular imaging for guiding, such as Japanese style? We can prevent all modes of the instant restenosis. So do you think this is a good idea?
For me?
Yes, for Dr. Dũng.
Yeah. I think before I have some measure of intravascular imaging, I think I can do many cases without intravascular imaging. But particularly some case with instant restenosis, we can perform only on the coronary angiogram. But with some case, I saw in the coronary angiogram look like no under expansion stent. Just I think it's the restenosis due to neo-atherosclerosis. But when I use IVL, oh, surprisingly, not neo-atherosclerosis, is under expansion. So but nowadays, with all the case with instant restenosis, we always use intravascular imaging. Similarly, in some case with complex PCI, it means a very, very calcified lesion. We do the rotablator, we do cutting balloon, and when we perform coronary angiogram, it looks very well, it looks excellent. But when we do the IVI, something must repair. So I think in all the case with difficult case or complex case, we should use intravascular imaging.
And that's all.
Yeah, can I get the panel's responses? what are your, how frequently do you use intravascular imaging to guide all your PCIs? Is it 10%? Is it 60%? Is it in select cases? Can I just get some people's responses as to how often intracoronary imaging is used?
In my center in Hanoi, Vietnam National Heart Institute, we just only use less than 10%. Just only some selected case like instant resources for left main or some calcification case. I think one of the very important reasons here in Vietnam is nowadays the reimbursement from the insurance not covered by all, just only some very specific indication like that. Yeah.
What about laser? Yeah, I'm sorry. Sandy, please go ahead.
Yeah, no, I was just going to say, you know, this is such a limiting aspect of intravascular imaging in America as well. The reimbursement's not great, and you know, it adds time to the procedure. I think it's the right thing to do for a lot of cases, not just the complex cases. And so our use of intravascular imaging in our lab has risen to, I think, overall about 60% of cases. For me personally, it's about 75% of cases uses some form of intravascular imaging. But you know, without reimbursement, it's really tough to get the rest of the country on board. I think nationally, it's probably in the 10 to maybe 15% range now. Historically, it's been under 10%.
Now, switching over to the concept of, let's say, some of the cases that you presented, Dr. Don, where there was a lot of plaque burden or a lot of neonatal hyperplasia, and also to get other people's thoughts of the role of debulking. Is there any role of debulking in select cases? And the data doesn't really support its use, especially in current day, but is there any role of debulking with laser? Sandy, I'll ask you just because you have laser available at your institution. So what are your thoughts?
Yeah, boy, I mean, it's a great question. I mean, I think you'll get lots of different answers depending on familiarity and institutional success rates. As you correctly mentioned, there is a paucity of data. And so it really becomes, in our institution, in our hands, how well does it work? I think that for long lesions, for diffuse ISR, and for what would historically be classified as a Moran class 4 lesion, a complete occlusion, it's probably worthwhile lasing. I think that laser is also very useful if you have a mix of expanded and unexpanded stent. So if you're going to use it for an underexpanded stent and use contrast lasing, why not just start with a laser and just lase the entire thing? Try to get as much debulking as possible. In the past, probably 15 years ago, I was using more rotational atherectomy for ISR, but there is a very real risk of burr entrapment and stent ablation. So if you've got areas of exposed stent, it's not without complications, as I think everyone is aware. Going through a prior stent or multiple layers of stent with rotational atherectomy. So that's gone down, but our laser use has gone way up. How about you guys?
I intend to have a question, but Dr. Sandeep Nathi, you have just talked. I'd like to ask you about your experience to use rotablator in debulking the plaque burden. Because in Vietnam by now we have just only rotablator, and some case with stent regret, but very short stent regret and stress and big diameter, large diameter. I intend to try the debulking with rotablator. It's okay. How about your idea?
Yeah, I mean, I think rotablator is fine. If you want to have a meaningful result in debulking, you're going to have to use a larger burr, a minimum of 1.5 and preferably 1.75, depending, of course, on the size of the vessel. Going through it with a 1.25 really doesn't do a whole lot in terms of debulking. One could also argue that the use of orbital atherectomy may be beneficial in a mix of neointimal hyperplasia and underexpanded stent, for the simple reason that the histologic data and the OCT data shows that you induce fractures in calcium. So it's off-label in the United States and everywhere. There's been a small body of experience with using orbital atherectomy. As I said, I think rotational atherectomy is fine. It's useful in certain cases, but we have shifted more towards lasing these and typically starting with either a 1.4 or 1.7 millimeter laser fiber. So something a little bit larger than what we would typically use.
Yes, in my case, case number 1 and number 2, I don't remember exactly. With the very large burden of the plug along big stand and very long, and we must use many times a cut balloon, because if we did not cut the balloon or carefully, the stand cannot the second stand cannot expand fully. But after the last result, it have a slow flow phenomenon, but not due to thrombus. I think due to debris of the plug go distal. Okay, thank you so much.
Yeah, we have 2 more minutes, 1 more minute before Dr. Nathan gives his talk. Any final closing thoughts or questions? Dr. Dung, any thoughts or final questions or? Okay, all right. Our next speaker is Dr. Sandeep Nathan from University of Chicago, who will talk about strategies for repeat revascularization after balloon angioplasty and stenting.